We're good to go.
Ready to go? Okay, so we are going to turn our attention to the lab. Dr. Phillips is going to demonstrate the high-volume radiofrequency lesioning of the spine. Dr. Phillips.
All right. Thank you for that spectacular introduction, Dr. Bill. I appreciate it. I know you don't know a whole lot about me, so I had to write something for you to say. But good morning, everyone. Welcome to the second annual Advanced Image Guided course. We're all glad you're here, and we're looking forward to showing you all the different technologies that we have today and that we can hopefully encourage you to implement in your practice. We're going to get started off today with radiofrequency ablation. You know, this is a pretty standard procedure that most all of us do on, pretty much every single day. Really, we're going to focus on the large volume lesion sizes. We have two different products here. We have the Nimbus needle, and we have the Avanos cooled RF system. Probably what I'm going to do is start off with just kind of talking about the dimension size. We have a chicken model here that kind of demonstrates the larger lesion size, and then we'll just kind of go over the different procedures that we can do. We have working with just the torso, we'll focus on the back, lumbar, maybe do a thoracic or a sacral if we have enough segment here. So with the large segment lesion, with RF, we're targeting the medial branch off the dorsal rami. Traditionally, we've got our multi-tine probes here. There's different variations. We have our just standard monopolar probes, and then these are this is the Avanos, this is the Stratus needle. Selection on various different types. We really want to focus on making sure we get the most area of lesion size over the nerve to really make sure that we have we adequately treat the nerve. The advantages to the larger lesion size are that we're right over the nerve area, and we reliably know that the lesion size will cover the area of the distribution and any variable distribution of the nerve. You can see here with the Stratus needle that it has the multi-tined probe here that protrudes out. What this does is it allows that the currency to go through there and the lesion size to be more of a prolate spheroid lesion size, so we can control and reliably know where the burn's going to be. The Avanos, or the cooled RF system here, is another large volume lesion probe. It uses water to circulate through the system and allow for the expandable lesion size. And so we're going to draw, I'm going to make sure here so we can kind of see up front kind of what we're talking about. If we're looking at the nerve here, you can see, traditional with a monopolar probe, we were going to really focusing on coming in parallel, getting along the nerve, coming more sitting flat on top of it like this, getting right over the top of the nerve. So I'll show you when we actually get to the model here. We're going to, oblique over, come back real caudally, so when our approach comes in, we're running parallel right there at the TP and SAP process where that nerve comes. We want to get right on top of it. The difference is when we're using a large volume lesion size is that we're coming more at a perpendicular approach. So we're coming more on top right here because we know that the lesion size dimensions will all reliably get this, but also have the large dimensions. So, depending on where it is, we got our probe out and it comes in like this and sits there on top of the nerve versus a more parallel approach where you need to be right on top to get that lesion size here. And so it would be more like, where we're getting it along like that. If you had the monopolar approach, you'd come in perpendicular, you would have just a smaller, you'd have to be really segmentally focused and not get that adequate lesion size. For these large segment or large lesion size probes, we're looking at, for the cooled about 595 millimeter cubed lesion size. And with the Stratus Nimbus needle, we're looking at 605 3 millimeters cubed, so much larger lesion compared to the monopolar probes, which are, 18 versus 20, somewhere between 150 millimeters cubed and 180. So, just looking at that, we're segmented over the nerve. We're covering a large segment so we reliably know that we're turning that nerve off. If you switch your focus over here to our chicken breast, you can see the different dimension sizes compared with the large volume size example here with that lesion there and the spheroid we're talking about, that prolate shape versus a monopolar single. And you can see the different sizes, the perpendicular versus having to be parallel, where you have to be right on top of the nerve to get that lesion to accurately ablate the nerve versus coming down here and having that large volume right over the medial branch. The benefit for that is that it can decrease the procedure time. Instead of having to get the right angle, get right over the nerve, multiple views, making sure you're laying right flat on the intersection of the TP and SAP, you can come down just in a perpendicular approach, going right at it and right on top. Well, we got these probes. We'll go ahead and just go to the model here. So far, just kind of what I talked about. Are there any questions over there about lesion size, why you would choose a large segment versus, monopolar? Anything over there in the lecture side? I don't hear anything, so come on in for me. Remind me your name? John. John. All right. We're going to take a shot here. I'm going to have you come down for me. We'll start our way down.
Dr. Phillips, we choose the larger volume ablation zone because it reproducibly gives us a better result due to the variability of the nerve. The medial branch of the dorsal ramus is less variable than some other nerves, but still the larger ablation zone gives rise to more consistent results if that nerve is in a variable position.
And on that, if we're talking about choosing between monopolar and the smaller lesion size versus the large volume segments, if we look back at Cohen's paper in 2020, the multi-specialty society paper on radiofrequency ablation, their consensus guidelines, they came out and said there's really no evidence or there's no discussion anymore about using the large segment. There's no debate, and it's safe. It reliably ablates the nerve. And so we've really, in my practice, kind of switched mainly over to doing these large segment lesions. And the benefit here, if we're just looking at this standard approach, if we were going to do, S1, we'll start at the L5, dorsal rami there. Depending on the person there, you have a high iliac crest, you can kind of change your obliques, and it makes it kind of challenging to come in and run it right up there along the nerve. So we'll take a picture here, almost right on it. Come down here. So it'll be a little low there. And the benefits of this is that I don't have to, oblique over 20 to my side, come back caudally about, 30 to 40 to get that in-plane approach where you're running right up on the nerve. Here we can go just straight down at it. Picture there. And target the border. We'll see here as I expand these tines, you'll see it on fluoro to know that we're right over the segment. I'm going to advance this a little bit further immediately there. Picture there. Picture. Got on. And when we deploy the tines here, picture, you can see that that's the distribution of kind of where the lesion size is. We can go take a lateral here, come around and switch, check our depth. Do we get enough room with the table? Yeah, you're good. maybe go down a little bit, pull it towards you. Yeah, it's really hard to see. Well, but, now once we have, we check our lateral, we check our depth. Next, we do sensory motor testing, watching for twitching of the superficial muscles here, making sure we don't have any stimulation for a motor nerve going down the leg, watching it jump. And then we're in place with the nimbus needle we could just hook up the probe, run the lesion time we burn at 80 degrees Celsius for, there we go. You can see a little better there, right on top of that nerve there. But we run this at 80 degrees Celsius for 90 seconds. The cooled RF system, we don't have the actual probes, but the standard needle comes with a connector piece that once you put the probe in, it comes in the water that's cooling the system as we use the lesion size. It has a piece that comes off. The difference between these two when you're using the Avanos system, we have one here, we'll show you, but you're running again 80 degrees. The difference is you're running for 2 minutes and 30 seconds to get that adequate lesion. So you can see here, this would be the probe that would go in, and it has the adapter piece that connects to the external port that pumps the water in, that keeps the temperature down and more stable for more stable and spherical lesion size. So we'll come back around.
Dr. Phillips, are both of these probes using different technology, or do they produce the same size, lesion size?
Yes. Like I was mentioning earlier, there's, not a significant difference between the two lesions. The Avanos is 595 millimeters cubed, and the Stratus is 605 millimeters cubed. And that large lesion allows you to reliably control. We're looking at the dimensions too with those multi-time probes. We worry about, especially in that parallel approach, we're checking lateral. We just don't want to be too close to the intervertebral foramen there. It's that motor nerve stimulation. Well, when we're looking at the distal projection of the lesion size for we'll say the nimbus needle here, from the hub of the probe, I don't know where it goes from the black to the gray, to the distal tip of the lesion is about 11 millimeters. Once the tines are expanded out, it's about 3.5 millimeters further. So it keeps the lesion size close to the tip and doesn't expand too far out away, distally. So you keep that lesion size right where you want it and not going further out. If you're right, close to the foramen, you reliably know that you're going to stay there. And it does that spheroid shape. We'll sit it right there. And so it's about, if we do the spheroid shape, it's, coming around like that. Total depth from here is about 11 millimeters. These tines right there is about 3.5. And then the total oblique is about 11 all the way around. And so we know reliably that these large segments, we know when we're down there, we're not worrying about that distal projection of the volume that we can get into trouble. So we'll just move up to that next segment there. We got a picture there. Give me just a little bit of a caudal tilt. And so if we were using a monopolar probe here, we would really have to, we would line up the SAPs, get a nice squared end-plate, superior end-plate, and then oblique over to you just a hair. Get the spinous processes right in the middle between the two pedicles. So, reliably there, if we were going to do the traditional where we're trying to get flat on the lesion, we would oblique over to me about 20. If you'll come to me, oblique about 20. Oblique, sorry. Not till, yeah, just keep it where we were with that SAP squared. Let's shoot that. And then we come back caudally about another 30. Other way, please. Thank you, sir. All right, let's see what that looks like. Go back, go to about 10. And really this, I'm just showing you the setup so that this will be our trajectory view. You know, we want, let's see if we can get this. Shoot a picture there. I mean, our path is going to be lined basically flat along that nerve. And so you got to get, you know, the angle set up so we can come in that trajectory view and to lay that down just on top of the nerve. And so you have to be, you know, very pinpoint, and, you know, some would suggest using, you know, multiple burn seizures to get the lesion size that we're trying to get with one, versus now just go back to that straight AP approach with a more perpendicular. This would be the parallel approach to the medial branch, just AP, straight where we were. A little bit more caudal. Oh, other way, please. Picture there. Picture here. Where we come down, picture. Just perpendicular to, and oblique over to me, maybe 5. Up, oblique to me. Right there at the intersection of the transverse process and superior articular process. So picture there. And we'll just come straight down. That's going to be a little too. Yeah, need to be a little bit superior there. And again, I'll show you on this, these needles are marked with a guide. We can see the way that the needle steers away from the bevel, and then the tines that protrude out go towards our marker, which, oh yeah, we'll set that here. You can see the marker there, the bevel's facing us. And then when the tines project out, they project towards, as you can see there, towards our indicator. So when I place these, knowing which way, where the tines are going to be deployed, I can match that up right where I want that lesion to go. And so picture, redeploy that. And I will turn this. Picture there. Bump down. But again, we're talking about the benefits of the perpendicular approach. We know what the lesion size, where we want to be. Oop. Picture. Now go lateral for me. The other advantage of knowing the control deal, large lesion size, when we're talking about other areas, the knee, for example. And so I would probably want that a little bit higher up there. Get it. You can come back around for me. But when we're looking at, doing a knee, for example, when we're doing the inferior medial lateral genicular, the recurrent fibular, and the infrapatellar branch off the saphenous, when our really thin patients or elderly patients, that there's not a lot of tissue that we get to work with, we worry about when we're running the the energy cycle about potential getting a skin burn. Shoot a picture, and so you can use these tines knowing the distribution of the tines. Give me a little bit more, take some of the tilt off, come back more standard, and we can control that so that we reduce any incidence of a skin burn. So I just need to be a little bit too high on the pedicle there. Picture. There we go. Move down. Right there. So now once we have our needles in place, we would hook up our probe. We would do the motor and sensory, make sure when we do the sensory, we're getting a similar pain pattern that the patient experiences on a day-to-day basis, and then do the motor testing, making sure we're not on a motor nerve that would get leg jerking. They feel it down their leg and would make us want to reposition our needle. Once we're there, I'm pretty generous with my numbing agent of your choice, really, because it can be a little uncomfortable. And so I will use bupivacaine, lidocaine, whatever they have, inject there, make it, numb it all up, make it nice. Once it's done, I'll inject a combination of a steroid and another numbing agent just to help with any of the soreness, post-procedure soreness, and potential for post-innervation neuritis that can have. And I've really cut down on the incidence of post-innervation neuritis by using that after the lesion size.
Dr. Phillips,
any questions?
Yeah, so we'll open it up a little bit to questions. So one question for you. So whenever you perform radiofrequency ablation, what is your, you've introduced two large volume radiofrequency ablation techniques. So why use larger volume?
Because we were talking about earlier too. I want, when I'm doing this, I want to reliably know that my lesion size can cover the variant anatomy. It's much less than some of the other nerves that we have. But if I'm going to do it, I can reliably know that when I'm over that target, I'm going to get that lesion and cover, like we were demonstrating earlier, that on that perpendicular approach, I'm covering the large segment of the medial branch as it traverses, and I don't have to be parallel to it to where I need to be right on top of the nerve, and it increases the variation of, or incidence of, missing the nerve and only, partial or getting a small segment lesion size. I want to, ablate as much as that nerve as I can when I'm down there on the target. And so the large segment, I can reliably know based on the size and the shape that I'm going to cover most of the trajectory of the nerve, and therefore hopefully have potentially better outcomes and longer duration.
Maybe the best evidence for this is actually in the knee. It's a genicular RF, more prolonged, better pain relief, more consistent over time. So with that, nice demonstration, Dr. Phillips, I'm going to open this up to questions, comments. Anybody have any questions? Yes, Charmaine.
So genicular RF, I mean, I go in, right? If you're using the nimbus and it opens up, it's not really going to be on. This bone is going to open up like this.
So the question is based on the trajectory, and thank you, by the way, here's a timeout slight reminder. Should have reminded you earlier. Whenever you ask questions, if you would, just either press the button for the microphone in front of you or use the handheld mic. This helps the people that are listening. There's lots of people listening on Zoom and YouTube. Just it helps hear the question. So the question, Dr. Phillips, was, is there a different technique because these large volume ablation zones go about 40% beyond the distal tip, would you come in directly on bone? Do you use the antero-posterior technique for the knee, for example, or do you come in directly on the nerve? What's your opinion on that?
So if we're talking, if we're doing lumbar, going straight perpendicular down, I don't need the anterior posterior approach as much because because of the lesion size, I can just be right over, the nerve versus coming in the anterior posterior line flat with a monopolar lesion. Again, in the knee, I'm taking into consideration body habitus, the patient's knee size, and directing my needle down because, again, if here's the bone, here's the nerve, the skin is, there's no tissue there at all. Again, with the distal projection of these tines, I can't just go straight down on top of it, and because then that increases the chance of me getting a skin burn. And so I take that into consideration if I need to start more anterior posteriorly coming down along it and turning my tines over the top like that, knowing that the spheroid shape reduces and injecting a big skin wheel around it to add more volume there just so I reduce it. So I take into consideration body habitus and size. But if we're talking about the lumbar, based on that 40% distal projection, I don't need to be along the nerve. I can come in here and I know that its course is there, and being on top of it, I get the same dimensional lesion sizes coming in parallel.
That's great. Well, with that, thank you, Dr. Phillips. Very nice demonstration. We will go ahead and move on to our next segment.